I'm fascinated because you talked about the polyclonal nature, or potential polyclonal nature of this disease and the heterogeneity, and I suspect like in other cancers you get emergence of new clones. How does that impact your treatment? Because we look at response criteria, but I'm not aware that any of these patients are being treated based on the development of new clones or on their heterogeneity of those clones. How does that impact your treatment?
It has a great impact. I would actually argue we physicians are responding to the fact that there are multiple clones in the patient, and we need to get deep responses in order to have a durable remission. And some part of those patients in deep remission, MRD negative, over a period of several years, are on the way to being cured. So we are having some surrogate markers who would be cured. Say MRD negative at 5 years could be a hallmark to say these patients are cured. There may be still a relapse at 10th year or 12th year, but most likely these patients could be even drug-free during that time. So I think it may look as if we are just adding drugs at the moment, but adding drugs is actually capturing more of the clone, and we are putting patients into deeper remission. And these patients have good quality of life. They are fully engaged. Younger patients are back to work with full force, so to speak. So they are economically contributing to this country. So I think that is good. But I hear your point, that is, why don't you segment and tailor your therapy? I think that will be coming as we understand the biology. Right now, the exploration is opening up many of these questions. So we are seeing more and more. It's like looking at the stars and counting billions and billions of stars are there. But my feeling is we will be able to come to a point that we would know this patient's immune system is so good that the daratumumab with immunomodulatory molecule may be adequate in maintaining the cancer for a longer period of time. And another patient, this patient may need a proteasome inhibitor and things like that. So I think the future is still coming there, plus newer drug options are coming. So I think this is, the most important I would say is the drugs are really bringing patients into deeper remission and bringing them better quality of life. The new drugs we added now, like monoclonal antibody, immuno-oncology, they have not added to the toxicity, adverse events for the patients. I will let you talk on financial toxicity.
Yeah. But I think that...
Can I bring one thing here? So I think what I heard you asking, John, is like, are we acting on biomarkers for treatment, tailoring therapy? And I think treating myeloma patients, Sundar and I treat a lot of patients with myeloma. We know from the genomic side that if you sequence these tumors, as Sundar pointed out, there are very many mutations that can be captured. You have gains and losses, you have translocations. It's a massively genomically altered disease. So unlike, for example, chronic myeloid leukemia or subsets of other solid tumors, where you can look for a particular marker and you can make treatment decision based on the marker. In myeloma, you find 50 or 100 markers per patient.
Yeah.
And within that same patient...
Those are the deletions and the translocations.
And somatic mutations.
Okay.
So, and as Sundar pointed out, even within a given patient, there are multiple subclones. So if you were to pick a very selected therapy to begin with, you may cure a subset of the disease, but the rest you won't touch. So you need to have these broader drugs. Yeah. So what we are seeing, I think, is that we are using the MRD testing right now to quantify the success. And if we see that the patient is brought down to MRD negativity, we declare that this is really a successful individualized approach. We use the best drugs up front. So that's the way we kind of do the individualized care for right now. But still the disease comes back.
So it'll be very interesting then if in the future that the treatment is determined by the risk factors and by the polyclonal nature of their disease. Because today we have that, what is it, the risk scoring, the revised international scoring system. But I'm not aware that that is dictating which treatment is being used. It sounds like we're going to use triple or quadruple therapy for all patients in the hopes of inducing minimal residual disease. And then we'll see what that translates into in terms of long-term treatment. Will that translate into reduced maintenance therapy or no therapy at all? I think that's, if we're going to invest heavily, and we are investing heavily in these patients, what does that translate to in the long term?
Right.
And we'll talk about some of those trials today.